Just want to take a brief minute just to introduce our panel. The full bios are in your folders. We have Dr. Stephen Hahn, who's a radiation oncologist from the University of Pennsylvania. We have Dr. David Sugarbaker, a surgeon from the Brigham. Dr. Harvey Pass, surgeon from NYU. We have Dr. Guardino from the University of Hawaii. Dr. Guardino is a basic scientist, PhD. We have Dr. Rafid Hassan, who's an immunologist from the NCI. We have Dr. Dan Sturman, who's a medical oncologist, pulmonologist, and is the head of the Mesothelioma Center at UPenn. And we have Dr. Raja Flores, who's a surgeon who's at Mount Sinai. And I think I squeezed too many people on one side. Would you gentlemen like a little more elbow space? I have no. Okay. All right. Dr. Hahn is going to have to be leaving a little bit on the early side, so I'm going to start with Dr. Hahn. Just a few questions about radiation oncology. So many of the patients are asking, what are the differences with these different types of radiation? We have the IMRT, we have proton beam, we have whole radiation. Could you just give us a little bit of a synopsis?
Sure. So I think it's useful to split it up into two types of radiation. One we call photons, but it really means just X-rays. And if you think about X-rays, when you go in for a chest X-ray, you stand up and the machine's in front of you and they point it at you and they put a film behind you. And that film gets exposed by tissues that the X-rays go through. So what that tells you is that X-rays go through and through you and hit the wall behind you. And so they deposit energy, this energy that kills cells throughout the tissues. So X-rays are relatively non-discriminatory about the tissues that they hit. Fortunately, we can aim X-rays at tumors or areas that we need to treat and then do that in fairly sophisticated ways to avoid treating normal tissues. So IMRT is just a more advanced form of delivering radiation. It has its own set of complications and issues associated with it, but it allows us to shape the beam in a more precise way than what we call conventional radiation. And then the second type of radiation that I think is useful to know about is proton therapy. So proton therapy is like radiation in terms of the way it kills cells, but it actually stops at a fixed distance from entering into the patient. So if you aimed protons at a tumor and put a film behind the patient, you would see nothing because it doesn't go through and through the patient. So it delivers approximately 50 to 60% less dose to the normal tissues compared to conventional radiation.
And in proton beam, are there any clinical trials now in mesothelioma, or are we still waiting to get that story written?
Yeah, no, none that I know of clinical trials with proton therapy. Actually, I think one of the issues that's really important is that we need a more advanced technique for mesothelioma patients to avoid treating the lung. And so there's a new type of proton beam therapy called pencil beam scanning, which is a 4-millimeter spot of protons, which you can paint very precisely in areas. And pencil beam scanning should allow us to treat more precisely areas within the chest and avoid the lung. So we actually are applying for a grant to try to develop this technique in patients with mesothelioma after
Wonderful.
pleurectomy.
That's great to hear. Wonderful. Another question about radiation therapy. Do you have a preference in terms of the type of therapy that would use following a PD or following any extrapleural pneumonectomy?
Yeah, so after an extrapleural pneumonectomy, I think there's a lot of heterogeneity. There's a lot of differences that people feel about whether you should deliver radiation after surgery for a patient who's had an extrapleural pneumonectomy. I think Dr. Sugarbaker was on a publication from years ago regarding the use of chest wall or chest radiation after extrapleural pneumonectomy. And you have to be really careful with it because if you scatter a lot of dose to the other lung, it can be quite dangerous. So we typically at Penn, if someone undergoes an extrapleural pneumonectomy, and not just for mesothelioma but for other types of tumors, particularly tumors that we consider to be radiation sensitive, we will deliver radiation to that chest cavity after removing the lung if we think that patient's at high risk. And typically we do think that because it's difficult to get all the cells out, and that's why we do other adjuvant therapies. So in the extrapleural setting, that's typically what we would do is we would treat one side of the chest with radiation, and we would typically use IMRT, paying very careful attention to the dose to the other lung. And then in terms of after a pleurectomy, There are some publications where radiation oncologists have looked at using conventional radiation, so that's X-rays, the ones that go through and through you, using conventional radiation to treat any potential microscopic disease after pleurectomy. We tend not to do that because the lung dose tends to be very high in the lung that had surgery, and also the doses are not really high enough, I think, to even have a reasonable expectation of killing enough cancer cells. So we tend not to do that after pleurectomy. I'd be interested to hear what Harvey and David have to say about this. In terms of other indications after pleurectomy, we would typically treat, we would consider treating if there's chest wall involvement, particularly if after a biopsy or something there was growth into the chest wall. There is a randomized trial that showed us in mesothelioma patients that you could reduce the risk of recurrence in the scar if you gave radiation to the scar after surgery. We don't do that as a standard procedure, but after pleurectomy, particularly if it looks like it's the type of tumor that does that, we'll consider that to the scar.
And I guess a question for the surgeons, when we talk about doing a pleurectomy and the possibility of doing some radiation therapy on those patients, I'm beginning to sort of notice a trend. We have a lot of survivors out here, and a lot of patients, especially after pleurectomy, it's more common where they'll relapse in the lung. So you do have an opportunity to go back in, and I imagine if you radiate, that makes it very difficult to go back in and operate on those patients. Dr. Sugarbaker?
Well, yes, I think that in terms of which operation we do. The goal really is to get a macroscopic complete removal, so there's no tumor left behind that you can see. And then we, would consider at our place intraoperative chemotherapy, where we do a regional high-dose chemotherapy. Now, what that does, particularly with pleurectomy, is it significantly changes, as you're alluding to, the pattern of recurrence in terms of the time to recurrence and the pattern. So in terms of radiation therapy, it would be very specific and only used in selected situations after pleurectomy. After a extrapleural pneumonectomy, particularly in those cell types where local recurrence is more likely, we have a long history of using conventional radiotherapy very safely. And there is, data now that suggests that local control is enhanced from the Australian group and others, the Toronto group, that there is enhancement of overall survival and particularly local control of the tumor after pleural pneumonectomy. So I would say in terms of radiation, more commonly after extrapleural, that's one of the advantages of the pleural pneumonectomy, particularly on the left, is that you can give radiation treatment to where we know it's most likely to recur, which is locally. So in certain situations that it has an advantage, particularly with, as I say, the more aggressive cell types, which we used not to treat, but we're now seeing, we just presented a paper at the American Association for Thoracic Surgery showing a doubling of survival for patients getting intraoperative chemotherapy and a significant improvement in survival in the mixed or sarcomatoid. So radiation therapy is a very important part of mesothelioma treatment, and the selected use versus the routine use, I think, is up to individual centers and their experience with it.
Dr. Pass, could you comment about the use of neoadjuvant chemotherapy before surgery? What type of patients that you think should have it before?
I think that's sort of out of the box in the United States at this point. But there have been trials that show that it is a very reasonable way to go. So the best way to show that is to do a randomized trial, but that's never going to be done. But the trials that have been done were done with surgeons in the United States, with Lee actually running it. The trial that was done in the United States actually showed a median survival of about 22 months for patients who got the full cocktail. But patients did even better if they had a response to therapy before they got their extrapleural pneumonectomy. The problem with the whole idea of neoadjuvant cocktail, which is essentially the induction chemotherapy, the surgery, and then the postoperative radiation therapy, if you're doing an extrapleural pneumonectomy, is the attrition that happens for these individual components. As you get closer and closer to radiation therapy, patients fall off the curve and they don't get the radiation therapy. So there's been criticism from some of our colleagues in Europe that it really doesn't really add much to the treatment of mesothelioma patients, while in other parts of Europe, the Swiss group, that has pioneered this, they actually were some of the leaders. So there's a lot of controversy about the use of induction therapy. My own feeling is that we really don't have a choice anymore, because the majority of the patients that are presenting to me are patients that have already been treated. So they have been treated with either pemetrexate and platinum or something else, most likely pemetrexate and platinum. So when they present to me, they've been induced. And then the question then is the question that David and I struggle with is what is the operation for them, and then what is the postoperative treatment? My own thoughts about the original question about postoperative radiation therapy is that I absolutely do agree with the early studies that Valerie did, that there is a lengthening of survival of patients who have, and local control in the early stage, at least stage 1 and 2, who got postoperative radiation therapy to the hemithorax. I support wholeheartedly the trials that Ken Rosenzweig is doing at Sinai, which are very, very important to show whether you can actually do pinpoint radiation therapy postoperatively in the patient who has a pleurectomy decortication. And in fact, I have a follow-up question for Steve, which is what's the difference between tomotherapy and SBRT, if there is a difference, because I just want to be educated. But I'm from Missouri on that, on the postoperative pleurectomy decortication radiation therapy. So pass, if you're from Missouri, what the hell do you do with the pleurectomy patient? So I actually will advocate for more chemotherapy after my pleurectomy decortication patients. So they will get either a different regimen, or we actually are doing other things, just like David is, and looking at the tumors and seeing whether there's actually some sort of hint as to what would be the best postoperative cytotoxic for that patient. So I think the postoperative management is very difficult. Believe me, in my series also, I don't know what it is, but there are some patients also that get postoperative radiation therapy, and they don't have toxicity, but there seems to be a rapid recurrence. And I think it's a very select group of patients, but I just wonder if that is some sort of systemic effect that's happening with these patients. So, tomotherapy?
Yeah, so that's a good question. And by the way, Harvey, I agree with you completely about Ken's studies. I think it's a really reasonable thing for us to take a look at and study. So tomotherapy is it's not just, but it's a specific way of delivering X-rays, again, the ones that go through and through you and hit the wall behind you, but they deliver it in a circular fashion, almost like a CAT scan around the patient. So they have the advantage of giving a little bit more shape to the radiation dose compared to conventional IMRT. It's not a huge advantage, but it is a little bit of an advantage. One of the other negatives that I don't particularly like about it is that it does tend to spread a lot of dose to the other lung, and that, yeah, David's shaking his head. That is a problem. So I'm not against it as long as you're careful of the doses. And then SBRT is a completely different situation. It is the use of a very focused and high dose of radiation to a small area. So radiation is typically given, and as Harvey points out, over several weeks, so usually 6 weeks or so. And it's fractionated, so a small dose is given every day, because we learned a long time ago that if you're treating really large areas, you can't give a lot every day. But if you have a small little tumor nodule, you could potentially treat it with very high dose radiation. And you know, Harvey, your point about the differences between radiation and how it affects patients is really, I think, that's something that we're learning more and more about. And there was a recent case report in the New England Journal about the use of SBRT as a way of stimulating the immune system. Because when we give these high focused doses of radiation to tumor nodules, it actually has a different way of killing the tumor cells, and it releases tumor antigens into the circulation. And so a lot of folks are doing trials now of stimulating the immune system with this small focused radiation. So it's an interesting approach, but very different from the hemithoracic radiation we talked about.
I just want to ask Dr. Flores a question also. Dr. Flores, in terms of, you people really are the doctors who do so much have made so many publications on the surgeries, and you're really driving the field forward. The patients in the room here, obviously, most of them have had treatment, but on Facebook we have a lot of newly diagnosed patients, and how do they choose a surgeon? What do they look for in terms of, do they need to travel? And if they are going to travel, how do they choose among the surgeons? And how do they know that their surgeon is really a mesothelioma expert?
I think that's a very difficult question, especially when you're faced with a disease like this. The first thing you get when you look at the internet is nothing but discouraging information. And it's hard to sort of identify where you should get treated, and it's different for every individual. I think first you want to make sure you go to see a surgeon that has experience in doing this. You don't want the local thoracic surgeon doing this. You want someone that has a lot of experience for two reasons. One, because if you get any kind of surgical treatment, experience matters in not just your long-term outcome, but your short-term outcome, sort of recovering in good shape from this big operation. There are, a few surgeons throughout the United States that actually have focused their careers in treating this disease. And, you've got two of the biggest ones here, Sugar Baker and Pass, Valerie Rouge, who have really been the pioneers in mesothelioma surgery. And so what you want is someone that has a vast experience, but also what you want is someone that's going to know exactly what is best for you. So a patient who has, let's say, a stage 2 mesothelioma, it's the type of treatment that patient gets is going to differ based on many different factors. So just because you have that stage 2 doesn't mean that you need an extrapleural pneumonectomy or that you need a pleurectomy decortication. And it's up to the surgeon to know who you are and what you expect, and to speak with your family and get to know the big picture, and then to treat you based on what is the big picture. So, for example, you have a stage 1 35-year-old woman with mesothelioma, newly married. Of course, you need to go to town on that patient to treat them. If you have an 85-year-old man with a stage 1 mesothelioma who's, doc, listen, don't ruin any quality of my life. I want to be able to go fishing with my grandkids, etc. You need to treat that patient differently. So I think you need to go to a surgeon that will take the time to see exactly what you expect, what is possible based on your histology, your stage, your functional status, and who's going to treat you appropriately. One size does not fit all, and you need to gear the treatment to that particular patient.
Thank you. Dr. Sturman, we had this discussion a lot about immunotherapy, and we have a lot of patients that are, taking all kinds of preparations to stimulate the immune system to fight their disease. And I know that, you do gene therapy, and gene therapy has a component of immunotherapy in it, and now you give chemotherapy with it, and everybody's a little confused if you're, if you're working on your immune system and you're giving chemotherapy, which some has referred to as a poison, or that it hurts the immune system. How do we explain this to a patient, how they sort of work together?
Well, first of all, I would say that one of the great fallacies of chemotherapy is that people think automatically that when you're getting chemotherapy that it actually is a hindrance to your immune system helping to fight your cancer. And what we're learning more and more is that not for all chemotherapy drugs or combinations, but some of them actually, as they kill tumor cells, they actually may stimulate your body's immune system. And so what we're trying to do now is to find ways, and Dr. Hassan is doing this as well, to try to harness that stimulation that certain chemotherapy drugs give to your immune system and give it a boost. So, for example, right now we are delivering a gene to tumors to essentially activate your body's immune system against the tumor and then give chemotherapy at the same time, literally, to try to magnify this effect. So the idea being that you can get the killing of the tumor that you would get with chemotherapy, but you get the added bonus of having your immune system be activated, and that to stay that way for months and potentially years, so that if new tumors develop, your immune system will recognize them, attack them, and either keep them under control or destroy them. And so I think the idea is that chemotherapy is not the enemy of the immune system. Chemotherapy, if designed correctly, can work together with immunotherapies. And more trials at our center, at the NCI, other hospitals around the world are trying to do this, which is the idea of doing chemoimmunotherapy. The combinations work better together than they do individually.
Mm-hmm. So, Dr. Hassan, you're an immunobiologist, am I correct?
Yeah, I'm a
Okay.
medical oncologist.
And a medical
dabbling in
oncologist.
immunology.
Okay, so my question to you then would be, you know, you're working a lot with patients who are on clinical trials, and they're also taking, many of the patients actually in the exam rooms do not really admit to all the different supplements and medications that they're taking. Do you have a problem with them taking supplements while they're on your clinical trials?
Yes, we do. So if patients are on clinical trials, we want to make sure exactly what type of supplements they are taking, because we don't know any interaction with new agents, and there could be unknown interaction. So in general, we ask the patient to stop the supplements that while they're on the clinical trial to avoid any untoward side effects.
Thank you. The surgeons that are here, not only are they, you know, really esteemed, wonderful surgeons, but they're also terrific researchers. They're doing pioneering work in mesothelioma, and I really actually asked them here to share some of what their research interests are and where we're going with the research. Dr. Pass, could you talk a little bit about your biologics and the markers that you're working on?
So, you know, maybe David's younger than I am, so maybe David still can tough it out on those days when he's doing 2 extra pleurals, but I'd like to have patients that are a little bit earlier. So one of the things that we've been doing really for the last 8 years is trying to figure out how to find the disease earlier. And it sounds so simple because, you know, you have patients who are exposed to asbestos, you ought to be able to just screen them, you ought to be able to just find them. It doesn't work. So the question is, how do you make it work? Well, you have to find markers besides CAT scans and x-rays that you don't know when to do those, you don't know how to do those right. You need to have markers that are easy for the patient, so we look at blood. And frankly, how we discover what to do in blood varies depending upon the technology. I mean, we started out looking at individual genes, and now we look at 50,000 genes. David's doing whole genome sequencing that he'll talk to you about, looking at every mutation in the tumor's DNA. But for us, we just look at the genes and we look at what's different between the parental origin cell, which is mesothelium. I mean, it's mesothelioma. So the mesothelium is like the normal lining. So we just take a tissue and match it to the patient who we've operated on that had an extra pleural pneumonectomy, because we're in the belly, so we harvest normal mesothelium, which is the peritoneum, and we look at the difference between those genes. And then the proteins that are coded by those genes, some of those are going to be secreted. So then if you can figure out what's the difference between the normal and the tumor and which ones get secreted, then see how different they are. And maybe there's a test that you can find either online, they call it an ELISA, where you can look in the blood and measure that protein that's supposed to be different. And that's really what we've done. There are other ways that you can do that. You can actually look at the DNA in the blood, you can look at the RNA in the blood, you can look at small RNAs in the blood. And I think what we're looking for is a marker that is going to not only differentiate people who are exposed to asbestos from mesothelioma, so we can find it earlier, hopefully, when the marker starts to change. But we need to find that marker that's also going to say, this marker is not telling you the patient has an infection, because we get infections in our chest too. We don't want that marker to go up. And we also want to say that that marker tells us it's only mesothelioma. It's not lung cancer, it's not ovarian cancer, it's not prostate cancer. So the search for that marker is a very difficult thing, but a word to the wise, stay tuned.
I thought I was going to wrestle a secret, Dr. Pass.
Stay tuned in about 2 months.
Okay. He's not going to spill it here, folks, no matter how hard we try. Dr. Guardino is with us, and Dr. Guardino, Dr. Krug actually spoke a little bit about the BAP study. And Dr. Guardino is a principal investigator on that study, and I'm going to ask him to talk a little bit about this gene and what it means to mesothelioma patients. Dr. Guardino?
Yes. So yeah, we heard about BAP1 mutation by Dr. Krug this morning, and they found a somatic mutation of this gene, which means a mutation located in the tumor cells. And we also ran this assay, and we found a very similar percentage of somatic mutation among mesothelioma patients. is about 20-25%, which is relevant and important. But our contribution was to find these mutations of BAP1 in germline DNA. That is, in the DNA of, that can be inherited and can be passed from one generation to another. And this started with the concept of gene-environment interaction. We all know that exposure to asbestos, but also to other natural fibers, carcinogenic fibers, lead to mesothelioma. However, the incidence of mesothelioma is not equally distributed among the exposed people. This is well known. So we started to look for a predisposition gene, and after a long search, we found in 2 unrelated families in the United States with an unusual high incidence of mesothelioma and a moderate exposure to asbestos, so there was no occupationally exposed. And we found this germline mutation, and all the patients of mesothelioma of these 2 families had a germline BAP1 mutation. And when we look at the tumors, we found that also the other part of the gene, you know that the gene are represented in 2 copies, also the other allele was mutated. So it seems as this BAP1 predisposed to mesothelioma, and it's also important to maintain the malignant phenotype of the mesothelioma. However, we also observed that some members of the family also developed another type of cancer, which is ocular melanoma or uveal melanoma. And this cancer is very rare, almost as rare as mesothelioma. So it was quite interesting to observe 2 different rare cancers bearing the same germline mutation. What can be the importance of this discovery for the mesothelioma patients? In parallel to our study, another group, European and US based, they discovered that BAP1 germline mutation predisposed also to another kind of cancer, actually not really a cancer, the so-called melanocytic tumors. These are mostly benign tumors. They can, in some rare case, they can evolve to melanoma, but usually they are benign, and they develop quite early in life. And so we started to think that BAP1 germline mutations are not just linked to mesothelioma, but maybe they are linked to a syndrome, to a cancer syndrome, that predisposed to different type of cancer. Not all cancers, but some type of cancers. And the use of this discovery, at least we cannot exclude that BAP1 may become a target in the future, but we need to work harder to understand the function of BAP1 and what is the consequence of mutation of BAP1, and maybe we will find something. We are working hard on several hypotheses. But as of now, this germline mutation can be useful because these melanocytic tumors develop quite early, and they are easily detectable by a dermatologist. And so we are encouraging our family to look for this, for these skin tumors, and in case of positive detection, we encourage to test the BAP1 individuals also at early stages, at early age. And this will prompt a follow-up of these individuals to look for uveal melanoma by ophthalmology, and of course for malignant mesothelioma. And in this case, the biomarkers that Dr. Paz was mentioning are very important, because early detection of mesothelioma is so important for the survival of the patients, and we believe that by this germline identification of BAP1, joined with the right markers, we can help to the early detection of this disease, and this might be very, very important for the patient survival.
Thank you. I think also that it's something to bear in mind for everyone in this room and for people that are listening. These discoveries are being made because patients are going to mesothelioma experts who are doing research. And when you go to a mesothelioma expert, you sign a consent form that gives them permission to examine your blood and examine your tissues. And this is how we're going to cure this disease, by people going to the right places, by volunteering to participate in these studies, and really helping us learn all those issues that we need to learn. Dr. Sugarbaker, now you've been working on mapping out the genome, and we're kind of interested in that and what it really means.
Yes, you know, there's sort of two areas. I just wanted to comment on the idea behind chemotherapy stimulating the immune response and working together. I think that's very important. And one of the areas of our research is to give high-dose chemotherapy that's been heated up, so-called hyperthermic chemotherapy, at the time of surgical resection in the operating room. We can give it almost 3 times, a little over 3 times the dose into the abdomen where we know this recurs, as well as into the chest where it's just been removed. And we're looking at the immune stimulation of that. We're now using 2 drugs, gemcitabine and platinum. So we look forward to following that. In terms of the genetic research, we have taken the approach of, as Dr. Pass mentioned, whole genome sequencing. So much of the research, very valuable research, will look at particular tissue samples to see if a particular gene is present. And our approach has been, although it's been rather expensive, but we've been able to raise substantial funds from a number of our supporters to do this, is to take a tissue sample and essentially look at every single gene that's there through a technique called high throughput sequencing. So you get all the pieces of the puzzle on a table. You may not know what they mean, but you have all the genes and the mutations of the genes assembled. And our goal right now is to develop for each individual patient a mutational profile. So we do the whole genome, and which is all the DNA, and we look for a profile of a certain number of mutations which are located. And we are finding about 20 mutational buckets, if you will, or profiles that most patients now seem to fit into. And for each one of these series of mutations, there's about 16 mutations, there is a known pathway that can be inhibited. So there are drugs on the shelf in pharma companies around the world that have been shelved for the following reason. Most chemotherapy drugs used against mesothelioma have been very effective in 6 to 8% of patients. That means 90+% of patients don't respond. But for that small number, there's complete responses, there's a literature about that. So if you're a pharma company and you have a drug that works in 6 to 8% and doesn't work in 90+%, it goes on the shelf. But what we're looking for is a cocktail of drugs that will be driven by an understanding of all the mutations that are present, a so-called mutational profile. And so we're looking to develop a cocktail of drugs, 2 or 3 possibly, that would interrupt the pathways that are mutated. And so our research is really into the concept of looking at the entire genome, looking for a cluster of mutations, and it looks like it's about 20, but then again, with about 5 or 6% of patients responding to different drugs, you'd expect about 20 different buckets, if you will, or profiles. So that's the way we're working right now, is in what's called high throughput sequencing, looking for all the genes present and then looking for these profiles of mutations.
Dr. Pass?
So I'd like to comment on that. I mean, you know, some people just go out there and do it, and it doesn't matter how much it costs. And I think that it's very important that we understand that David did this with his own funding, at a time when it was incredibly expensive, and he continues to do it. And the importance of this is that if one person will do it in this rare disease, which nobody wants to do a lot of research in, then people start to listen. So what's the outgrowth of something that he does in Boston with his own patients? Well, in fact, there's this thing that the National Cancer Institute up yonder at Bethesda has been doing with all those big tumors, lung cancer and breast cancer and ovarian cancer and a small tumor, glioblastoma. Well, now and it's called the Cancer Genome Atlas, TCGA. They've actually seen that this can be done, and there is now an effort that has been ongoing with tumors now being collected from all over the country as well as from Europe to be able to do the exact same thing that David has been doing, but Uncle Sam's going to pay for it. And the beauty of that is that when you get another 200 tumors that can be sequenced like that, then what you can do is you can be sure that what David has is correct, and you can validate back and forth and learn from the two cohorts. So it's really important to show that one crazy fool who's going to spend money like this, it makes a difference.
I think on that note, after calling Dr. Sugarbaker a crazy fool, we'll move over to this side. Dr. Hassan, your focus is really on a protein called mesothelin. Could you tell us a little bit about mesothelin as a target and what you're doing?
Sure. So our focus at the NCI is to develop new treatment options for patients who have either progressed after surgery or not candidates for surgery or have progressed after chemotherapy. So our efforts over the last 15 years have been focusing on a protein called mesothelin that was discovered in a lab in Ira Baston's lab about 15 years ago. And over the last 15 years, in collaboration with other investigators as well as pharmaceutical companies, we have developed a number of new drugs which are currently in clinical trials. And these are mostly immunotherapy-based agents, including a naked antibody to mesothelin called MORAb-009, which we did a phase 2 trial, presented the results at ASCO this year, and hopefully we'll be presenting updated results at the IMIG meeting this year. So that is an antibody by itself. In collaboration with Bayer, we are doing a clinical trial of an antibody-drug conjugate with the goal of using the antibody to target a chemotherapy drug to mesothelioma, and this trial is in phase 1 testing. In addition, we, in collaboration with Adura Biotech, we have a mesothelin vaccine. This is a bacterial Listeria monocytogenes encoding human mesothelin. And we did a phase 1 clinical trial in patients with mesothelin expressing cancer, but a new trial will be opening up in the next couple of months where we'll combine immunotherapy targeting mesothelin with chemotherapy for newly diagnosed patients with mesothelioma. So this is one of the first examples in a solid tumor using immunotherapy with chemotherapy in the frontline setting. We are also doing a clinical trial using an anti-mesothelin immunotoxin. It consists of an antibody to mesothelin linked to a bacterial toxin called PE. And this drug, SS1P, we completed a phase 1 clinical trial, and we currently are evaluating SS1P in patients who have previously progressed on treatment. So we have a lot of different agents which are focused on mesothelin, and so we're very excited about that. In addition, in collaboration with Steve Rosenberg at NCI, we're conducting a clinical trial of a mesothelin chimeric antigen receptor, again for patients who have previously failed chemotherapy.
Thank you. Dr. Flores, at Mount Sinai, I know that you have a very, very long-standing history of working with the Frost and Insulators Union, as well as studying the health of first responders. And interesting, yesterday when our patients were at the Hill, they met a first responder who has developed mesothelioma. And I'm wondering if you could speak a little bit about, your work there and what's happening at Mount Sinai and what we can learn from these groups.
So I think there are a bunch of different things that you're hearing today. And what you're hearing about the work being done in mesothelioma is being done in all cancers, and many cancers that get a lot more money, like breast cancer, et cetera. And there's a lot of work being done in genetics, and we're also doing that in our lab. What I think is unique to the research in mesothelioma is the ability to develop a novel agent that you can use in the operating room. Maybe that stems from 15 years ago when I was under the tutelage of Dr. Sugarbaker back in Boston, when I was intimately involved with putting this chemotherapy into the chest. I think we've got to find another novel agent to put in there that's going to make a difference. And I think a lot of the research in genetics, et cetera, sounds very attractive. It sounds like we do this, and we'll find a cure. And you know what? We've been doing that in a ton of different cancers. And in lung cancer, one of the biggest things, EGFR, tyrosine kinase inhibitors, Tarceva, Iressa, oh my God, we're seeing these dramatic responses. But you know what? We're not seeing any cures from it. And I know, speaking to many of the patients out there, that they want a cure and they want it now. Unfortunately, we don't have anything. We've got a lot of things that sound pretty good, but they're not resulting in cures. And, you know, as a surgeon, I have to keep things simple. The only way that I can help result in cures are by seeing it and cutting it out. And what's the best way for me to improve the cure rate? And it's to catch it earlier. So I think all the research being put into early detection is very important. Like in lung cancer, there was a recent randomized trial that came out in the New England Journal that showed that patients who were screened, who are identified with lung cancer with CAT scans compared to chest x-ray, 20% decrease in mortality. And I think we need something similar to show that in mesothelioma, that when you catch it earlier, you do get a longer survival rate. So we're doing a lot of research with regards to that. The thing that's unique to Mount Sinai is that we have the Selikoff Center. For those of you who don't know, Irving Selikoff is the one that found the relationship between asbestos and mesothelioma. And there's a whole center at Mount Sinai that looks at occupational medicine and looks at the cause of these different types of tumors, mesothelioma being a big one. What we're doing now is when we get a patient who really can't pinpoint where they've had their asbestos exposure, what kind of job they did, then we have our whole team that's going down to that place, investigating it, and trying to figure out where they got their exposure, not just to treat that particular patient, but so that we can identify other patients who are at risk and hopefully identify their mesothelioma earlier. So we're looking at it more from a epidemiologic standpoint as far as who's at risk for mesothelioma. Can we pin down exactly where was their asbestos exposure? There was an attending at Sinai, her name is Jackie Moline. She said, everyone who has mesothelioma has been exposed to asbestos. You just got to find it. So that's what we're trying to do right now with our research. I was recently doing research over in Libby, Montana that many of you may have heard about. Libby, Montana is a small town where there was such a high incidence of exposure to asbestos from the mines, et cetera. Many patients died very quickly from asbestosis and from mesothelioma. And so what we're trying to find is not only the exposure aspect, but also is there a genetic component as well, which Dr. Pass and Dr. Carbone have shown that there is a definite genetic component. Why do some patients who are exposed get mesothelioma and other patients who are exposed not get mesothelioma? But right now at Sinai, we're focusing on the things that we can actually intervene on right now, and that's early detection and identifying areas where these patients are getting exposed. And our biggest cohort of 30,000 patients are the first responders, where we are seeing patients who have lung cancer and mesothelioma, but it's only been 10 years, and I think, you know, we will see a much greater numbers in the future. But these patients are suffering from things other than mesothelioma. They're suffering from asthma, they're suffering from sinusitis. Many of them are having gastroesophageal reflux, which we know is a precursor to esophageal cancer. And I think there are going to be a whole slew of things that develop that we're not aware of right now.
Mm-hmm. Thank you. And I would presume, too, that, you know, with all this screening, you're going to really be picking up early mesotheliomas, and we'll actually know, does it really make a difference treating early, or we'll have enough numbers to understand that better. Dr. Sturman, we're talking a little bit more about, the immune system and stimulating, and I know there's been a number of publications now about your photodynamic therapy. Could you tell us a little bit about what's going on with that, and, how does it apply to patients?
Sure. Well, I defer to my colleague across the table in some cases. Dr. Pass actually is one of the world's authorities and initiators of studying photodynamic therapy for mesothelioma, and did one of the first randomized trials of this novel technique 21 years ago, I think, Harvey. It's been a while. You must have been 14 years old. You were 14. So photodynamic therapy is an interesting treatment which we call novel, but has actually been around now for quite a while. And it involves the injection or the ingestion of a drug which will get into all the cells of the body and then over the course of the next 48 hours be cleared by most of the normal cells, if not all of them, and be retained within the cancer cells selectively. And we still don't know for sure why cancer cells tend to retain this drug, which is called a photosensitizer. But the drug itself is non-toxic, so unless the patient is exposed to light of a particular wavelength, the drug will sit there for a period of time within the cancer cell and do nothing. However, if you expose that cancer cell to light of a specific wavelength, and this can vary depending upon the drug that you're giving, so not all light will activate each individual drug, but you give light of a specific wavelength, it will initiate a cascade that will cause that cell to die. So a selective cancer death given by a drug which is by itself non-toxic, and by light which by itself is not a burning or a thermal energy, it just delivers light to a specific area. And then not only do those cancer cells die, but more and more what we're learning about is how they die. And they die in such a way that they stimulate the body's immune system to create a response against the tumor. So in some ways, this is the perfect idea for what Dr. Flores was talking about. So you're in the operating room, and while you're there, you want to give the patient the best chance for a cure. So what can a surgeon do? All a surgeon can do is go in there and remove all the tumor that they can see. But there's, unfortunately, in mesothelioma, often tumor that they can't see that's still there, that's microscopic. And so what we're doing at Penn is in the operating room using this photodynamic therapy to treat the microscopic disease that my colleague Joe Freeberg can't remove, even though he's a superb surgeon, but he can't remove the microscopic disease. So while the patient's asleep, we give this treatment. Now it's similar in concept to what Dr. Sugarbaker's doing with the heated chemotherapy. We're trying to accomplish the same goal, which is to both treat the microscopic disease, but also potentially to stimulate your body's immune system so that if a recurrence tries to happen, that your immune system will recognize it, attack it, and destroy it before it occurs. And so Dr. Freeberg and our team recently published a paper in May in one of the premier thoracic surgery journals called the Annals of Thoracic Surgery. And this described our experience with lung-sparing surgery and intraoperative photodynamic therapy for patients with mesothelioma. And what we showed was that we're not achieving the goal necessarily that Dr. Flores said, that we're curing lots and lots of people. We hope to do that. But what we are doing is extending the life, and we are changing the way mesothelioma grows in patients. And we're taking it from a rapidly progressive disease to one that becomes slower growing and patients can live with and live longer to get other therapies that we're all working on. So we have a long way to go to perfect this, but the idea being that we can give something in the operating room that will both kill residual tumor cells, enhance the immune system, and ultimately work better together with other drugs and other immunomodulatory therapies.
Thank you.
Mary,
yes.
I have a question for Dr. Hahn about that. Do you think there's a difference between what the surgeons are doing in the OR with chemo or immunotherapy, stimulating the immune response, in comparison to radiation given afterwards?
We don't know the answer to that question, but I believe that there is, and I think, not all radiation is the same. So Dan's talking about non-ionizing types of radiation, the light treatment. And it has a different way of killing cells and likely a different effect on the immune system than fractionated radiation than does SBRT. And we're just beginning to understand this. In fact, the NCI is actually putting some money into trying to understand the interaction of radiation with the immune system and how the different ways that we apply it might affect that. So I think, yes, the answer to the question is it's likely to be different, although we're relatively ignorant about those effects right now.
For the people at the table, if you have questions, if you could write them down. Maya's going to be bringing us some of the questions here that we can ask. Dr. Robert Taub and Dr. Kruger in the back, they're manning the Facebook station, and they're busily responding to lots of questions from people on Facebook. Dr. Sugarbaker, while I'm waiting for some more questions to come up, I have a question for you regarding the genome. When we talk about mapping it out now, and you're seeing some of these mutations, and we're talking about maybe having some targets, what happens after chemotherapy? I mean, do we have additional mutations, and are we going to need to get more samples? And after radiation, I would imagine.
Yeah, you know, that's a very good question, and I think what we've all seen in a variety of different tumors is after chemotherapy, there is a clonal expansion, meaning there are certain cells in every tumor that don't respond to chemotherapy, and when you kill off all the ones that do, you're left with the ones that don't. And then they begin to proliferate, and you begin to get, you know, a recurrence pattern. And the same is true in mesothelioma. So what is the genomic alterations afterward? It's a great question. There's no data. We're still, I think, doing our best to figure out what the whole genome is in mesothelioma patients and tumors to begin with. But we expect that there would be a significant change. You know, if you think about, you know, your growth or the growth of your children, there is a revolving expression of genes as someone grows. And it's much like spinning one of these old round things with a light in the center, and it would throw lights around. You know, we feel that the genome is constantly changing, and that the RNA production of proteins, and the proteins is what you see, there's protein in your hand and in the tumor that you see, that it's constantly changing. And so we look at it at a specific point in time when it's been biopsied, but undoubtedly there'll be changes.
Mm-hmm. And then I have a question, I guess, for the table. I'd like everybody to sort of weigh in. A lot of times tumors are being sent out for chemosensitivity testing, and you know, there's been so many papers that have come out now on cell signaling and how, you know, you metabolize drugs so differently. What is the value of sending the tissue out? Do you feel that it has a value and it's relevant today, or are we moving beyond that? Dr. Schwager?
Well, we've published a profile of mesothelioma chemoresistance testing. Now, there's chemosensitivity testing and there's chemoresistance testing. So chemoresistance testing is to say that a particular drug, when applied to mesothelioma tumor cells, that the tumor cells show no resistance to the drug, meaning the drug works. But the measurement is to see whether the tumor cells are able to resist the drug, and that's chemoresistance testing. Chemosensitivity testing has been around for a long time, you know, I think we're still waiting for the big bang. I'd like to hear what Harvey and others think about chemosensitivity versus chemoresistance. It's been hard to keep a company in business. I followed, you know, a number of companies from beginning to bankruptcy, and I'm still waiting kind of to see how chemosensitivity or chemoresistance affects, you know, patient treatment.
Mm-hmm. Dr. Pass.
So, I've also done the chemosensitivity stuff, mainly in lung cancer, and I've seen some remarkable things, but I'm not so sure that it's really a repeatable phenomenon, and I don't know why. And like David says, you have at least 2 different companies that are doing this, and some of them are on a major basis, some are on a minor basis. My own thoughts on this have really changed, and that's because I'm a damn fool too, I guess. And for full disclosure, I mean, I'm on an advisory board for a company, and the newest approach, and David's familiar with this also, is I think that what we're finding is that in vivo, meaning put the tumor into an animal and then see if you can expand it in a lot of animals, and then treat the animals with various agents to see what happens, to me is a very interesting approach, mainly because not only for the clinical side of it, to see if it predicts what will happen in the patient, you know, in the animal, in the patient, but also you're taking a tumor and you're putting it in animals that have really minimal immune system, and then you can go ahead and study those tumors too, just like we study in the animals. So we can do the whole genome sequencing, we can do microRNA stuff, we can do protein stuff, and we have oodles of reagent to work with. But independent of that, the one, I've dealt with one company that is through Johns Hopkins, mainly because I know the investigators and I know their science. And I think that if you have a mesothelioma that you think is going to be a patient that you resect and and the median time to recurrence, you know, we all talk about this, is it 7 months, is it 10 months? 7 months is going to be enough time that if you're going to develop a tumor that you can then expand it in 100 animals and also do the testing, 7 months should be enough time. So if that patient then recurs with mesothelioma, then you can go back to these data and see what are the 5 regimens that you gave to those mice did the animal respond to. So that's a wild-ass idea. My ideas are usually stupid or they go in the neighborhood of wild-ass. And this is one of the new wild-ass ideas that we're trying to work with this company. Whether it's going to work and whether you have the time to treat mesothelioma patients like this is subject to debate. But what I can tell you is that, as seen with other tumors, you can establish these tumors in animals to the tune of about 92%. So you can get a graft and you can get information from that graft 92% of the time.
Thank you. Dr. Sturman, just a question from the Facebook. Is there any evidence or any thought that childhood vaccines play a role in development in mesothelioma?
Wow.
Why do I get that question?
Because I knew you would handle it nicely.
I'm sure you can answer it real well.
Can I pass this on to someone else up here at the podium?
Your choice.
I know of no evidence.
Okay. Thank
That's
you.
my short answer.
Dr. Flores, could you talk about different terms, what it means to have a recurrence, what is no evidence of disease means, and what is cancer-free? And I guess in terms of mesothelioma.
Yeah, those are very tough questions. It sounds like something that should be straightforward, but those are very tough questions. And when you look at the papers and the studies, it's very important to understand what each of those things means. So when you do surgery for any kind of cancer, what you want to try and get is something called an R0 resection, which means that you got all the cancer and there's nothing left there. Now for mesothelioma, I think all the surgeons up here and in other places will sort of admit that we can't get an R0 resection in mesothelioma. And what we can best hope for is something called an R1 resection, which is where you got all the cancer out that you can see with the naked eye, but that there's going to be some microscopic stuff there that you can't see. And then an R2 resection is where you're in there with surgery and you cut everything out, but then there's tumor in one area, whether it's invading the aorta or some other structure like the heart that you can't cut out and you have to leave the tumor there. And that's an R2 resection. But with surgery, what you're trying to do is get something called an R1 resection. So then the question is there a patient that's ever NED, no evidence of disease? So you can say no evidence of disease based on CAT scans, based on PET scans, but theoretically, we know that surgery doesn't get everything out. And that's where all these other things come into play, radiation afterwards, chemotherapy, etc. When you have and when you're looking at the research studies, you want to look at the survival or the time to recurrence. So when does that time start? Does it start when they were first diagnosed with mesothelioma? Does it start when they first developed shortness of breath about a year ago and then they finally got diagnosed with mesothelioma? When does that time start? So when you're looking at the research studies, you want them to strictly define what's the survival time. And when do they count the time of recurrence? Is it at the time when they see something on a CAT scan? Is it at the time when something pops up underneath their skin and they can see, oh my God, I've got some tumor that's back? So depending on what study you read, those things will be defined, hopefully within the methods sections. But what I would take away as a patient is that if you had surgery, Did they get all the gross disease there? So in other words, did you have an R1 resection? If you did, then that's the best possible case scenario. As you're being followed on your scans, if there is no gross evidence of disease, then I would call that patient NED, no evidence of disease. Now, you got to realize when you follow up patients with these studies, CAT scans, PET scans, you've already had big surgery in there. So there's going to be a lot of fibrosis. There's going to be a lot of scarring. There's going to be a lot of things that you can say, is this meso? Is it not meso? And it can scare the hell out of you as a patient. What I would say is ask your surgeon. Say, what do you think this is? Most of the time, it's going to be some type of scarring after surgery. In time, if it's meso or not, it will declare itself. But I would be sure that if you're a patient and you get these scans that show these different findings, don't automatically jump to conclusion, oh my God, that's meso, I'm a goner. And talk to your surgeon because they were in your chest and they can tell you, yes, you have disease that's back, or no, this looks like scarring and you're fine. So I don't know if I've defined those things for you, but this is as simply as I can put it.
Thank you. I'm going to give Dr. Sturman another chance for a question. Okay, Dr. Sturman, do we have different treatments for patients with sarcomatoid mesothelioma?
So I don't know that we know yet whether there are best treatments for these patients. I think that we know that there are treatments that aren't as effective. And there's good data from lots of the people who are sitting up here today that, for example, aggressive surgical approaches and multimodality approaches involving surgery, chemotherapy, radiation therapy may not be as effective in patients with this rarer variant of mesothelioma, maybe about 10% of patients, than they would be for the epithelioid patients, which are 60 to 70%. Dr. Sugarbaker alluded to some recent data from his group that suggested that maybe some aggressive techniques might be better in this patient population. And this is really exciting and needs to be followed up on, and maybe we'll try to participate in some of his studies as well. But in general, patients with sarcomatoid mesothelioma don't respond as well to chemotherapy, to surgery, even potentially to radiotherapy, although this is not well known. One of the issues with sarcomatoid mesothelioma is that the markers that exist on the surface of the mesothelioma tumors that are very common in epithelial mesothelioma, including the protein that Dr. Hassan talked about called mesothelin, are much less common. So for example, the studies that Dr. Hassan has mentioned, all the trials that are going on at the NCI, some of those that we're doing at Penn and elsewhere, may not be applicable to patients with sarcomatoid mesothelioma because they don't have this protein on their surface. And therefore, if you have a treatment which is targeted against this variant of mesothelioma, it may not be effective. So for example, we have a clinical trial right now which uses your body's own T cells to try to fight mesothelioma. But for those patients with sarcomatoid mesothelioma, because the T cells are targeted against this protein mesothelin, the trial is not open for those patients because the chances of them benefiting are too small. So I think that we need better therapies, and the therapies I think are going to come out of these genomic studies that Dr. Sugarbaker and others are doing, because what we need to find out is what genes they're expressing and what targets we can then use to attack this subtype, which is so difficult.
Thank you. Dr. Hassan, peritoneal mesothelioma patients, are they included in your trials?
So some of the patients with peritoneal mesotheliomas are included on a trial, especially if those are phase 1 or early clinical trials, because we are targeting the particular protein. So yes, so they would be included in some of the trials, but some of the trials are specific for pleural mesothelioma. So it depends upon which trial we're talking about.
But there are some trials that peritoneal patients are eligible for.
Absolutely.
Good, okay. We do have quite a number in the group, and they were very interested in that. Dr. Sugarbaker, a question for you. When we do neoadjuvant chemotherapy, and I know that you do, you'll do in some patients, if they don't respond prior to surgery, are you giving different agents into the pleura?
You mean, okay,
So in other words, I'm sorry, I probably didn't phrase the question correctly, but do you use the same agents neoadjuvantly that you use during your surgery?
Many times that's the case if we use induction gemcitabine. Right now we have used the Gemzar platinum intraoperatively and use the Olympta preoperatively in situations where the lymph nodes are involved prior to. it's interesting. We have a number of cases with neoadjuvant therapy where there's no change in the silhouette of the tumor on X-ray. There may be some reduction in the PET scan signal, but the actual scan itself hasn't changed. Yet when we take that tumor out, we find that it's 90+% scar tissue, maintaining the same picture and therefore engendering a lot of pessimism as to whether or not the patient could even undergo surgery because things haven't changed with the chemo. And in those situations, we would use this alternative strategy during the surgery, which we think is really the best of both worlds, which is now you've got 3 different agents, the pemetrexed or Olymptip plus platinum, and then the platinum plus Gemzar at the time of surgery.
Thank you. Dr. Pass, for a patient with a stage 4 patient, what makes them non-operable, and is there any new techniques or new ways of looking at combining radiation with therapy, with surgery, to make these patients operable?
Well, stage 4 usually means that the patient has disease outside the chest, or in the belly. It means it's outside the belly in the chest, or a patient that comes to me who has disease in one side and then has a nodule on the other side, and then you biopsy it, and it turns out that it's meso on the other side. That patient is not usually going to be one that I'm going to put through a big operation. So I think it's very difficult I mean, what we're trying to do here is we're trying to get the best possible therapy for patients. And we're only as good as our worst margin, although margins are difficult in meso, but we sort of skirt that and say we do as good as we can with a maximal cytoreduction, which is the way we do it. But then to have disease elsewhere that's uncontrolled, I think many of us would think is just not really right for those patients. So what does that leave us? It leaves us with the idea that we need better agents, and it leaves us with the idea that we have to figure out how to treat patients individually. And those techniques are now being explored with the type of stuff that's David looking at, we're looking at in TCGA as well as Rafit.
I have another question, I guess for one of the surgeons, so Dr. Flores, I'll give this one to you. This is a question about, performing like extrapleural lumenectomies and, looking at survival statistics and wondering, should we be making a shift away from surgery and more into medical oncology, or do you feel that there has been significant progress being made in say, the recent year or two that would warrant that we continue to do these surgeries? I know it's a tough question,
Yeah, that's a very tough question, and just to preface it, there's a lot of controversy out there all over the world, here, Europe, Australia, with regard to the surgical treatment of mesothelioma, and it depends who you ask. You have a table here with 3 surgeons, and when you're a hammer, the whole world's a nail, right? So we treat mesothelioma by cutting it out. And when I get into this debate with the medical oncologist, one prominent one from Australia, I say, well, listen, the patients who are living the longest in my series are the ones who've had surgery. They're living 8, 9 years. And then she'll tell me, well, I have patients just like that who just got chemotherapy and no surgery. And it's a difficult thing to argue. Just putting it simply, throw out the whole doctor shenanigans stuff, simply put, what's the point of giving chemotherapy or of giving surgery? It's to get rid of the tumor. You want to get a scan where there's no tumor there. The medical oncologist will give chemo, continue to give chemo until they see some type of response, even, small response, 15, 20% response. With my knife, I guarantee 100% response. I'm going to go in there, I'm going to cut all the tumor out, and when you get your CAT scan, you're not going to have tumor there. Now, does that mean cure? No. In my own biased opinion, I think that means that they will have a longer survival. Can I say for sure that it's my surgery when they're alive 8 years later that did it? Honestly, I can't say that, but I would not deny patients surgery. Maybe it's just the way I was brought up in this field. However, my litmus test is what would I do if that were my family member? And if it were my family member, I would recommend that they get surgery. Chemotherapy, radiation, I think that all adds to the approach of mesothelioma, genetics, immunotherapy, etc. But in my heart, if that were my family member, I would say you got to cut this thing out.
Yeah, let me just comment. particularly when he talked about the way he was raised. I know,
Okay, Papa.
I know, and I could go on and on about those 2 years, or 3 years, I think. But
You're still in recovery, I think.
yeah, I'm still rebounding from it. But what I would say is, if you look at the data, let's get away from 1 8-year survival. Let's look at the data. Let's look at the large number of studies that have been done. We heard about the prospective randomized trial between cisplatin in one arm and platinum pemetrexed in the other arm. 9-month median survival versus 12 months. Basically a 3-month difference. So what chemotherapy has to offer is about a 1-year average survival. Now, if you look at a number of studies, and I just presented about a year ago at the European Society meeting, the results of extensive literature review. And all of the long-term survival studies with median survivals anywhere from 22 to some of them 35, 36 months are surgical-based therapies, multimodality treatments. And it's not rocket science. If you start to treat a patient who has no visible disease with chemotherapy, you're going to have a better result. No matter what malignancy has been studied, the lower the quote-unquote tumor burden at the time of chemotherapy, the better the response. So to begin with a complete reduction from the macroscopic, we live in two worlds, right? The world we can see and the world we can't see. All we can do as surgeons is put the tumor into the world we cannot see, of single cells, of bacteria, viruses, whatever, and then go after it. And I think the data backs up an aggressive surgical approach to mesothelioma. Which operation? Obviously spare the lung when you can, that's what we do, but you've got to get all the tumor out that you can see, and sometimes that means removing the lung.
Thank you. Dr. Hahn, our radiation question. Patients who've already had radiation following a surgical procedure, can they get any of these new types of radiation? Are you able to go back and radiate any area of that same lung?
So it's always more dangerous to give any type of radiation after previous ionizing radiation. So not the photodynamic therapy that Dr. Sturman was talking about, but conventional types of radiation. So you can actually do that, and probably with proton therapy, because there's less dose to the normal tissues, you can give that after prior radiation more safely. We actually have a study at the University of Pennsylvania actually looking at that in patients who've had prior radiation to actually assess that. But because the tissues, the normal tissues, remember the radiation dose, and it's a long-acting effect, it can be very dangerous to give re-irradiation, so that is to irradiate again after previous treatment. So it really depends on the location, how much the tissues have seen, and then also to some extent the technique. So I have some hope that proton therapy will allow us to do that in terms of giving dose again. But in general, the answer is no, and there are some things like a patient's spinal cord that you wouldn't give more radiation to because the risks of paralysis, for example, are so high, or that you might not. You make an individual decision.
Thank you. The questions, I guess, would be for Dr. Hassan and for Dr. Sturman. In terms of patients who go on your clinical trials, say your SS1P trial and your photodynamic, not your photodynamic, sorry, your gene therapy trial, if those patients, I'm sorry, excuse me, those patients who have been on either an SS1P trial or a vaccine trial or gene therapy trial, and they've enjoyed a good response to their therapy, do you refer those patients on to surgery? And if you do, how do you make that decision?
So most of the patients that go on our trials are patients who either have had surgery before, or initially they were not candidates for surgery, or have progressed after chemotherapy. So if we have a patient who gets a terrific response and otherwise the patient is doing well, is fit for a surgery, we occasionally refer them to our surgical colleagues or ask them to seek opinion at centers where they have an expertise in surgery. But most of the patients who go on my clinical trial are not candidates for surgery. But if there is an occasional patient, we do refer them to the surgeon.
I would add the same thing. All of our patients are evaluated at a multidisciplinary conference and seen on the same day by all the members of our team. So they see radiation oncology, medical oncology, our interventional pulmonary group, and thoracic surgery. And if they're candidates for surgery, when they first present to our team, that's where they head, unless they don't want to go into surgery. So we believe in what Dr. Flores and Dr. Sugarbaker said, which is that surgery is a mainstay of the treatment of this disease, and everything else is an important adjunct for those patients who are surgical candidates. So for our gene therapy trial, we have a trial now where patients who are not surgical candidates, or for some reason they don't choose to have surgery, can have a combination of a gene therapy to stimulate your immune system in combination with standard frontline chemotherapy. And we have had patients who have been through that combination and, as Dr. Hassan said, had an overwhelmingly good response, and then we've been able to reconsider surgery in patients in whom they have not been candidates before. It's not common, and again, our approach is that if a patient has a chance for an operation, the best thing to do is not to wait to get them to the surgeon immediately. But we never exclude surgery in patients in whom it might be appropriate. So patients go through our clinical trial, we'll reevaluate it, and we have an open mind as to what the next steps should be.
Okay, Dr. Hassan, I have a question for you about your immunotherapy with your SS1P and the MORAb 009 that you had spearheaded. They're wondering, do you think that we're turning mesothelioma now into a more chronic disease?
Well, that's a difficult question to answer. So I would just stress that our clinical trials are still early. With the MORAb 009, we had a phase 2 clinical trial in the frontline setting, and so we're excited about those results. We have some patients who continue to live longer, but obviously we need to have a longer follow-up. Regarding the SS1P, we have a clinical trial now. We have been working with SS1P for some time, but a limitation of SS1P was that it's an immunogenic protein, and most patients develop an immune response to it, and therefore can get only one cycle. But over the last year, we showed in our lab that if we use a combination of two drugs, one is called pentostatin and other one is called Cytoxan. These are commonly used drugs in oncology. We show that in mice we can completely suppress the immune response to SS1P, and that has led to our ongoing clinical trial, which just opened about 6 months ago, where we pre-treat patients with pentostatin and Cytoxan, and so that we can give multiple cycles of SS1P. So this trial, as I mentioned, opened just 6 months ago. We definitely are seeing that we can give many cycles of SS1P, and we have some patients in whom there has been significant tumor response, which we're pleasantly surprised about. So I think these are early days, and we just need to treat more patients and have a longer follow-up.
Mm-hmm. Thank you. In terms of all the large centers now that see so many mesothelioma patients, are you seeing more young people? And is anybody tracking these numbers, and is there a way that we can get these numbers tracked? Dr. Flores?
I don't think we're seeing any more young people than what we were seeing 10 years ago. Mm-hmm. Now, you know, when you take into account things like 9/11, et cetera, where you put young patients in harm's way, then maybe we will start seeing it down the line. But we recently did a SEER database study looking at that, and there really didn't seem to be any trend as far as age was concerned. I don't know if Harvey or David has anything different.
Yeah, you know, I would comment just first of all on the SEER database. Everybody kind of may or may not know what SEER is, but the SEER database is 13 states that have done very careful review of tumor incidence. But the problem is that mesothelioma is a regional problem. So in New England, with all of our shipyards, we have a lot of mesothelioma, but there are no New England states in SEER. Upstate New York, other places, California, Northern California, are not in SEER, so it's hard to say. I would say that our median age has gone from 71 to 60 point something. So we've seen a 10-year drop in the average age of patients. And I would say that there, as we were talking earlier, there's a rise, in my experience, in women prior to the age of 50 who come down with this disease, particularly younger women in their 20s and 30s, something which I haven't seen. And I've seen kids as low as 16 to 18. Just had a patient who was 18 years old, a young girl. So I'm seeing younger patients. It may or may not be reflected in SEER or in some other centers, but I would say that's a definite trend.
Dr. Pass?
I think that the decrease in the age ranges over the last 10 years, at least in my series also, is because there's more people who are getting interested in surgery. I mean, I think the surgery has been shown to be safer, and more people are coming for a surgical evaluation than used to. But as far as seeing younger patients, yes, I do see younger patients, but the volume, the number, really difficult for me to say I'm seeing more than I saw before. But the answer is, the phenomenon is, yes, it's there, and you see it in young people. And yes, I agree with David that I think that there is a trend toward more women than we used to see.
I'll just like to make a comment, because I also see patients with peritoneal mesothelioma. It may be just because of referral patterns. Clearly have a lot of patients who are teenagers or in the early 20s, especially women, with peritoneal mesothelioma. And my youngest patient, 8 years old, and I'm also treating a patient with peritoneal mesothelioma who is 12. So it may be just referral patterns, so it's difficult to say. But clearly have a cohort of patients who are teenagers or in the early 20s.
Thank you. Dr. Sturman, you know, we have a lot of people here who are concerned about their family members. What type of families would you refer to screening? And do we screen?
Well, right now there is no standard recommendation for screening. I think that I talked about this at this conference, I think a few years ago, and reviewed the data. It was 2009. And we have no recommendation. I think a lot of the recommendations will come out in the next few years now that we have the BAP1 gene, and we know that there are certain families that who have this gene may be at higher risk. So I think that there's a lot of data that will be coming out in the next few years, but unfortunately currently there is no recommendation. Dr. Flores referred to this landmark study that was done in lung cancer that showed the benefits of screening in high-risk patients. And these are patients in whom they are of a certain age category, 55 to 74. They smoked a pack of cigarettes a day for 30 years or more. And we know that that group benefits from screening. In mesothelioma, we don't know who to screen. And part of the problem is that screening is expensive. It can be risky, so getting CAT scans does expose patients to some radiation. And the numbers of people who've been exposed to asbestos are huge, and the numbers of mesothelioma are relatively small. So to screen people who are exposed to asbestos is very difficult. It's expensive, it's risky, and we don't know the best way to do it. So I'm very frank with families. I understand their concern. I think that we'll have more data coming forward in the future, but we have no recommendation.
And we certainly will post and let you know about any clinical trials that develop for screening, but we're just not there yet.
The one thing with screening I think that should be touched upon, you know, people will argue, well, you screen these patients, you find them earlier, but whatever treatment you're doing, is that resulting in a better outcome? The one thing you can say for sure about screening is if you catch it earlier, you have a greater chance of sparing that lung, of doing a pleurectomy. The later you catch it, the greater your chances are of getting an extrapleural pneumonectomy. So just keeping it simple like that, I think, is in favor of screening.
And also, Dr. Flores, a question for you about 9/11. To date, are you aware of any figures of how many patients have developed mesothelioma that were among that cohort?
We do have a few with mesothelioma and with lung cancer. However, I'm a little reluctant to sort of put percentages down, because the question is whether those patients were in high-risk occupations to begin with that predisposed them to getting it. 10 years is not a long time. So I'm a little reluctant to put any of that data out. I don't think we'll be able to do that for another 10 years probably, but we have had patients who were at 9/11 who've had mesothelioma and lung cancer, but we just can't say that it's as a result of 9/11.
And then for the surgeons who have these large series of patients, and you follow them regularly with CT scans, I imagine, do you feel that there's a risk for having these patients go through periodic screening, or do you feel the benefits outweigh the risks?
You mean you're talking about the follow-up scans?
Follow-up scans.
In terms of radiation treatments, you mean?
Yeah.
Well, I would say that it's always a risk-benefit, and so the risk of getting some type of malignancy with an adult whose DNA is very stable from getting a CT scan now, which are even lower radiation, is outweighed by the idea of catching a tumor early where it can be removed or radiated or treated in some other way. So the risk-benefit is strongly in favor of screening. And I would also, of follow-up screening, I would say. I would also say that when you look at the X-ray that you get from a standard CT scan, it's not as much as the pilot who flies from New York to Tokyo, okay? They get a lot more radiation than you get from a CT scan. So maybe that we should be more worried about our pilots in some ways. If you're a baby, that's a different story. But if you're an adult, the benefit of knowing what's happening with your tumor, particularly mesothelioma, is much more important than the minuscule chance of something happening based on the radiation.
Dr. Pass, do you have a certain rhythm that you do for scans after patients had surgery? How often and for how many years?
My lung cancer patients get CT scans every 3 months for the first 2 years. They get a CT scan every 6 months for the 3rd year, and then they get yearly CAT scans. For mesothelioma, it's 3 months and keep on going.
Okay. Dr. Flores, do you agree?
I get it every 6 months. I don't do the 3-month scan. The other thing, just to put it in perspective, a low-dose CAT scan, which is what we get, is about the same radiation as a mammogram.
As a what?
Mammogram.
Dr. Hassan, regarding the SS1P trial, does previously having the Pseudomonas virus preclude you from the trial because automatically would you have the antibody?
So the SS1P is a compound which consists of an antibody to mesothelin linked to a modified toxin made by the bacteria Pseudomonas aeruginosa. Most of us are exposed to this bacteria at some point, and about 5% of the patients develop antibodies to the drug. So as a prerequisite for going on the clinical trial, we do a blood test to determine if patients have pre-existing antibodies to SS1P, and if they have the antibodies, then they would not be eligible. But I would say the chances of being positive for antibodies to SS1P is less than 5%.
And a question for the panel, what do you think are the most promising therapies that are coming along? Besides say that, I know that we're all interested in the clinical trials that you're currently doing, but if we were to start looking at classes of drugs that possibly have some additional potential that maybe we don't have trials available for yet, do you see any new therapies coming down the road? Anything that we should be looking at?
Tackle this first?
Okay.
My bias would be towards immunotherapy-based approaches because that's what I work on. But I'm sure that
Mine too.
But I'm sure that there will be new classes. So far, the most effective drugs in oncology are chemotherapy drugs. So I think, as was pointed out by many speakers here, identifying particular mutations or signatures in the tumor will allow us to use chemotherapy drugs, which might already be in the shelves in pharmaceutical companies or in investigator labs, and will be targeting a very narrow slice of the pie rather than saying drug X will be useful for mesothelioma. As is happening in lung cancer, we need to identify the subset of mesothelioma patients who might respond to a particular drug. So we're already seeing this happening in lung cancer over the last 4 or 5 years. So I think that's probably what's going to happen and make a significant impact.
So can I answer that
Yes,
too,
please.
Mary?
Thank you.
That's okay. I have to agree, and I think that a lot of this is going to come from the studies that Dr. Sugarbaker and others are doing to find the specific mutations in each individual's tumors. So to me, the most exciting trend in all of cancer therapy is personalized therapy, which is that it's not just off the shelf, the same treatment for everybody. We're going to look at your tumor and through a variety of mechanisms, maybe not necessarily in everybody deep genome sequencing, but maybe just looking for specific types of mutations in your individual mesothelioma to be able to find drugs that may not kill everyone's tumor, but in your specific tumor are going to be beneficial. So that type of what's called targeted personalized therapy to me is the future of treatment for mesothelioma as it is for a lot of other cancers. And I think that I have to back up with Dr. Hassan with a bias that, again, I'm working in immunotherapy, but I think that we're now in a stage where there are increasingly 4 arms of treatment for cancer: surgery, radiation therapy, chemotherapy, and immunotherapy. And recently in melanoma And in prostate cancer, 2 drugs have been approved that are immunotherapy drugs and are changing the way we treat those tumors. And I'm hopeful that in the next few years for mesothelioma, we will have an immunotherapy drug. I don't know which one. Hopefully it'll be one that I'm working on that'll be approved, and that will be part of that 4-pronged approach to treat cancer. So there are a lot of new drugs that are being studied. The good news is that pharmaceutical companies are interested in immunotherapies, and they're investing a lot of money in looking at this. And so I think the combination of immunotherapy and targeted therapy with all the other treatments that we're talking about is going to change the nature of this disease.
I have a question. Do you think there will ever be a test or there ever be a method developed to remove asbestos from a patient before it can progress to mesothelioma? I guess.
The issue is whether you can figure out whether a patient has actually had an asbestos exposure. Because, you know, there are different varying degrees of patients. Yes, you know, I put down some insulation, you know, for 4 months. Well, did they get a significant asbestos exposure? Or did they get a response that was out of kilter that may be just as bad as somebody who worked with asbestos for 10 years because their underlying immune system or their underlying genetic makeup made them more susceptible? So in the Hawaiian laboratories under Dr. Carbone, there actually is a test that's now being associated with asbestos exposure, and it's called HMGB1. And the question is whether that's going to be the first way to actually just put all the people together to say, hey, wait a minute, you definitely are showing that you had some asbestos exposure, so you should be in a cohort that should be really followed carefully. The leap of faith then from that to then the development of mesothelioma with a blood test has to be through serial testing with specific other markers, I think. But that's ways away.
Okay, so that's, in other words, I know that Dr. Yang has been working on this marker, so we're not going to be seeing a clinical trial or a screening trial with this marker for a while yet, am I correct?
With HMGB1?
Yes, yeah.
Yeah, there will be a trial.
Okay.
I mean, if the spore gets accepted,
okay, right.
then at Sinai with Dr. Flores and Dr. Todd, there will be a clinical trial to show whether that marker is specific and sensitive for asbestos exposure and whether it can be modulated with very simple immune modulating drugs.
Mary, can I add a comment?
Yes, please.
So the question, I think, was whether or not we can remove asbestos from a patient who's been exposed to asbestos. And I don't think that we'll ever be able to do that. But the question goes back to what do we do in a screened population in patients who may be at high risk for developing mesothelioma but don't have it? What can we do? And I just want to bring back to a study that actually has been relatively forgotten. It was done in Australia. It was almost 10 years ago now. But they have a cohort of patients that lived in or near a town called Wittenoom, which is where they mine the blue asbestos in Western Australia, and probably the highest concentration of asbestos-exposed individuals in the world. And they actually had blood tests from these patients they could follow over a period of many time, and they knew who was going to get mesothelioma. And there was a small study that has yet to be duplicated where they gave a derivative of vitamin A called retinoic acid to a group of these patients. And they actually showed that they could, in this small group, decrease the rate, although it was never done on a randomized basis, decrease the rate of development of mesothelioma in this small group of highly exposed individuals. So there may be drugs like this vitamin A derivative or others that we'll be able to give in patients who've been exposed to asbestos, even though we can't get rid of it. They may prevent them from getting mesothelioma down the road. But first, we need to have that blood test that Dr. Pass talked about so we can identify those patients who are at high risk.
Okay, Dr. Hahn, if radiation is used to treat lung cancer, then why is it risky to use CAT scans for general screening for mesothelioma?
Could you repeat the question?
All right, let me rephrase. So in other words, we know that we treat lung cancer with radiation therapy, and we think radiation therapy is good and it has an effect on lung cancer. Why do we consider it to be risky, or why are we not using CT scans to screen for mesothelioma?
So I think they're two separate issues. Certainly, radiation can be effective in lung cancer, although I'd echo what Dr. Sugarbaker said, is if you can do surgery, you should. But it is an effective treatment. But the issue of screening, I think, is a little bit different. I agree completely with the comments that were made here about radiation exposure. the concern with radiation exposure with CAT scans for screening would be that it could induce a cancer, it could cause a problem, but that risk is extraordinarily low. And in patients who are at high risk for a cancer, that risk is very low compared to the potential benefit as long as it's been proved in a clinical trial. So in lung cancer, we have a clinical trial that shows improvement in cause-specific mortality, in reducing deaths from lung cancer. We don't have such a study in mesothelioma. So it's a little difficult to justify that because we don't have that benefit side of the equation. It doesn't mean that we shouldn't study this or look at it, particularly because I think the risks are quite low with respect to the concerns for cancers related to radiation exposure.
Okay. Dr. Flores, then, with the screening that you're doing with the frost and insulators and 9/11, are you using CAT scans?
Yes, we are using CAT scans. So we use a low-dose CAT scan. Like I said before, it's the same radiation as a mammogram. You know, I'm not aware of any studies that have documented that multiple CAT scans have led to any cancers. And if you're in a high risk, you know, you're always weighing the risks and benefits. And if you're in a high-risk group, I think the benefits of screening definitely outweigh the risks, as demonstrated by this randomized clinical trial.
Okay. Dr. Sturman, is there really a delayed response to chemotherapy, or is that a myth?
Interesting question, and I actually might defer that to my medical oncology colleague, Dr. Hassan, who's sitting next to me. I think that in general, most responses to chemotherapy are seen within a few cycles, so within, say, 2 to 4 cycles of chemotherapy. So the delayed response, meaning months down the road, I think would be highly unusual. One of the more interesting studies that I've seen in terms of looking at response in chemotherapy and kind of predicting response has been the use of PET scans. And this actually comes out of Italy, where after 2 cycles of chemotherapy, even before you may see a change on the CT scan, or the patient notices a difference, the presence of a response on a PET scan, a decrease in the activity, the metabolic activity of the tumor, can predict whether or not a patient is going to respond. So I think that the issue of delayed response, I don't think so much, but the idea of predicting response and preventing patients from getting unnecessary additional treatments or reason for pushing forward with the current treatment, we may have better ways of doing that.
I completely agree with Dr. Sturman. With chemotherapy, it is very unusual to get a delayed response. So either we're going to see a response or stable disease early on. But what is important is with immunotherapy, as we all know, in other tumors, there could be a delayed response, especially with cancer vaccine. But we are also seeing in some of our trials, especially with the PET scan, that sometimes there is a significant worsening on the PET scan after the first 2 cycles, and then later on you will see a significant improvement. We believe that the worsening of the PET scan is because of the inflammatory activity that's going on with the immune therapy agent. So we are very cautious in using the PET scan results for our antibody-based studies, so we rely mostly on the CT scan, but that's something that needs to be worked on.
Dr. Hahn, could you tell us a little bit about the difference between an MRI and a CT scan, and can they be interchangeable for patients with peritoneal as well as pleural mesothelioma?
Sure. So an MRI does not use ionizing radiation, doesn't use radiation to actually image what's going on in your body. It actually uses protons, ironically enough, and the differences in protons in different tissues to distinguish among the characteristics. So they can be complementary studies. So for many tissues of soft tumors, or of soft tissues, MRI gives a much better identification of the tumor compared to normal tissues than does CT. And that's true for some tumors, but not true for others. One of the complications for MRI in the chest is that it is also more sensitive to motion. Now, there are new techniques that have been developed to reduce that artifact in the evaluation of an MR. In general, for patients with mesothelioma, we use CT-based images, and it's a pretty good assessment of where the tumor is. It's reasonable. MR may add, and I'm interested in what David and Harvey had to say, with respect to pericardial involvement or diaphragmatic involvement. They may help in those areas as well. But in general, we use CT-based images. You can have an MRI. MRI is good for CNS tumors and other locations in the body. I treat patients with a soft tissue tumor called sarcoma, and it's a much superior way of identifying a tumor than a CT scan in terms of the borders of the tumor. But it really depends on the clinical situation.
Thank you. Dr. Pass, any preference when you follow your patients between using a PET scan or a CT scan?
I always use CT scan. I think that PET scan does have more radiation, and I don't think it's necessary. I think that you can use a PET scan to confirm whether you have a change in a CAT scan, and I think that is very, very valuable. But I follow my patients with CT scans.
Excuse me one second. Some of your questions will be answered by this panel, and some will be answered via Facebook. And at the close of the session, we will continue to answer questions on Facebook. And after the conference ends, we will also try to get all your questions answered. Let's see. Highly varied latency periods.
I have a question. Are you going to, the questions that are answered at this panel that you're recording, as well as on Facebook, you're going to post those on the website?
Yes. In fact, they're on the website now. Everything is going live.
Good. Yeah, I just got an email from a patient who
oh, did you?
saw
Okay.
one of the pictures of the panel and is asking me questions via email. That's good.
Why does this, okay, so I have a question, and I'm just going to open this up to everyone. Why does asbestos lay dormant for so long before progressing to asbestosis or mesothelioma?
Well, I have a theory on the development of mesothelioma, which is not all that complicated. We know that when you inhale an asbestos fiber, that within a very short period of time, cells take it from the airway, or what we call the bronchus, and take it out to the periphery of the lung, where the visceral pleura is. That's the mesothelium that covers the lung, and deposits it there. And I've got some beautiful electron micrographs of these asbestos fibers sticking out like sort of porcupine quills. And over a 20 or 30 year period, I think with potentially the chronic irritation, and we've got some other great EM photos showing mesothelial, mesothelial cells being speared, and actually deletions, genetic aberrations caused by particularly long fibers that we know are the most carcinogenic. So it may very well be, and of course anybody who's ever spent any time with mesothelioma will tell you that it starts on the parietal pleura. It starts on the pleura opposite the lung. That's where the early cases are. So it could be that there's this constant, something as simple as just constant irritation over every time you breathe. Right, that lung slides across pleura to pleura, and so that's my theory. Take it or leave it.
I think that inflammation has a lot to do with it, but here's a little fact for you. Asbestos kills mesothelial cells. Asbestos doesn't transform mesothelial cells. I mean, if you take asbestos and put it on mesothelial cells in a petri dish, they all die. But why do some of them not die? And it actually turns out that the asbestos actually has an effect on other cells. And it makes other cells secrete things that actually turn on pathways within the remaining mesothelial cells to resist further death. So what happens is that the majority, it's like a nuclear bomb, the majority of the mesothelial cells are going to die that are in the close proximity of where the asbestos is. But the ones that remain, because you have macrophages, which David is studying, that come in and secrete these nasties that make actually the remaining ones that stay alive stronger, so they resist further damage. Well, if they resist further damage, then what happens is that if you've got a cell that got screwed up with a mutation, that cell now is going to continue to grow. It's not going to die. So then it's going to take 25, 30 years for the expansion that David mentioned of those cells that were able to withstand the asbestos injury to then turn into a mesothelioma. So it is a long process. It's not like taking a cigarette and smoking 4 or 20 times a day and you're constantly bombarding your lung with tobacco carcinogens. With asbestos, it's a dose that comes, not as high and has an effect that actually is prolonged.
Thank you. Dr. Guardino, I'm going to end the session with a question towards you. I think we mentioned earlier that we have some nurses here that will be drawing blood, and we have some consent forms taking place in the break room after lunch. Dr. Guardino, could you talk about the type of patients that are here today that might be, might be eligible and that you might be interested in studying?
For sure, patients with or individuals with a family history of mesothelioma, and anybody that believes may have these skin lesions that are early manifestation of this possible BAP1 syndrome. And so we were very interested in looking at the BAP1 mutation, and because this will help to screen and periodically screen the patient to look for possible mesothelioma development.
Okay, and for those of you who are on Facebook, with Dr. Guardino, what we're looking for are people who have a family history of other people with mesothelioma in the family, uveal melanoma, or different types of skin cancer. Those people who are not present can get in touch with me, and we can take care of the consenting, and we can get some lab tubes out to you, and you can have labs drawn by your local doctors. We'll require a family history as well, a family genetics history from the grandparents down. And all of this will be done, it's all done under an IRB-approved protocol. Names and identities will be removed, so your data will be safe and it will be secure. And again, it's something that's going to help all of us to fight this disease and to learn more about mesothelioma. We're going to take a break now, and then we're going to be having lunch at 12 o'clock. Thank you, everyone, and thank you so much to the panel. You were great. Thank you.